afternoon, Dr. Huda.
Good afternoon, sir.
Are you ready for this case presentation? You are sitting in your OPD and some patient had come with this X-ray. You do not read X-ray, see the X-ray, whatever you feel. So first you can tell what X-ray X-ray is normal or subabnormal. So don't read, just see the X-ray because you are JR3.
Yes.
You have enough experience.
Sir, it is an abnormal X-ray, sir.
So according to you, it is an abnormal X-ray. How confident you are while you say this is an abnormal X-ray?
Sir, I'm quite confident.
You are quite so your confidence is very high. In the maybe I believe in the tune of if I bracket you 25, 25, 50, 50 to 75, 75 to 100, which bracket you take?
Sir, 75 to 100.
So 75. So you are pretty sure that this is not a normal X-ray. Okay?
Yes.
If this is abnormal, naturally the next question comes. What are the abnormality? And what do you think patient may have problem?
Sir, to begin with the X-ray, sir, we can see bilateral reticular nodular opacities in the lower zone.
So bilateral reticular nodular opacities in the
lower zone, sir.
Lower zone. Okay. So with this, that is one finding.
Yes, sir. And the patient might come with the complaint of, sir, breathlessness and.
No. I haven't asked you yet. Don't go fast.
Okay, sir.
So a reticular nodular shadow. So anything else in the X-ray?
Sir, there is volume loss of the left, left lung.
Volume loss of the left lung.
Yes, sir.
Okay, not the right lung?
No, sir. When compared, yes, sir.
So there is some volume loss according to you on the left side. Okay.
Yes, sir. Sir, and there is hilar prominence on the right side, sir.
And there is a hilar prominence on the right side.
Yes. Sir.
And no other finding.
No.
Nothing in soft tissue, bony case.
Sir, bony case in soft tissue appears to be normal.
Okay. What are the points in the history would you like to know in this case?
Sir, to begin with the basic complaints, cough, breathlessness. Sir, whether it was insidious in onset, progressive. So then we would ask about certain exposure history, that would be pet exposure, occupation history, so joint pain, so drug history, occupation history, pet exposure, cattle exposure history, joint pain history, smoking history. Yes, sir. So these are the significant leading questions that we would ask the patient.
So patient had cough and breathlessness for last 9 months, right?
Yes, sir.
And it was a dry cough, no expectoration, and breathlessness used to increase on exertion. There is no history of drug intake. There is no history of joint pains. There is no other significant. She was non-smoker. Would you like to know her age? What do you expect?
Yes,
what should be the age? In 2000, what should have been her age?
Sir, around late 40s or 50s, sir.
Around 55 years. And what are the other point? Any other points in the history would you like to know? As you said, there is some volume loss. Would you like to know history of
tubercular
history of treatment in the past? Would you like to know?
Yes, sir. Yes, sir. ATT history.
So ATT history. Would like to know whether she has received ATT.
Yes, sir.
Well, she was prescribed ATT for about 3-4 months. What else you wanted to know with the ATT history?
Sir, whether there was any response, any adverse drug
So
reaction, and the duration.
she had no response, and of course she also had no adverse drug reaction, but no response. So what she consulted another doctor, and when she went to that doctor in the past history, she was prescribed inhaled medication, combination of steroids and the LABA, right?
Yes, sir.
And she took it for about again 3 months, and again history she told that she had no response in cough as well as breathlessness,
Yes, sir.
right?
Yes, sir.
So that was the history of treatment. So anything, what else you wanted to know in history? That was a past history.
Exposure.
Would you like to know the family history?
Yes, sir. Yes, sir.
What you like to know in the family history?
Sir, whether someone suffered any similar sir, disease and or someone would have passed away with the
No,
same complaint.
what do you mean by similar disease? You don't know the diagnosis, so what similar
Sir, as
symptoms you
in,
might ask?
yes, sir, similar symptoms. Suffering
Might
from
ask
similar
similar
symptoms.
symptom.
Yes, sir.
Okay. So she has told that in her family there were 1 or 2 persons who had asthma-like history. They suffered from asthma. Anything else in the history would you like to know? Personal history, you have known that she was non-smoker, no
Non-smoker,
alcohol.
yes, sir.
She was house lady, housewife. No occupation. You don't want to any occupational
Sir,
history.
I told earlier, sir, occupational history, we would ask whether she was exposed, so biomass fuel exposure or any such exposure, sir.
Okay. She had no biomass fuel exposure. She used to cook. She belonged to a good family. She used to cook on uh, LPG gas. So now with this much of history, how will you proceed to examine? What? I mean, the main things you will examine.
Sir, starting with the general examination, so we would first see for a clubbing,
Yes.
sir, any evidence of sir cyanosis,
Okay. Very good.
and sir, then would see for sir the other signs, sir, we would see pallor, icterus, so raised JVP or any lymphadenopathy, visible lymphadenopathy,
Yes.
and sir, significance on sir clubbing and cyanosis.
No, clubbing and anything else you would like to see? You said clubbing, cyanosis,
Sir, edema.
JVP, JVP, edema or feet.
Ji, sir.
So these are the important issues, and she had uh, stage 2 clubbing. Only
Yes.
finding in general examination, she had stage 2 clubbing
Yes, sir.
and no others. How will you proceed further?
Sir, we would proceed, sir, with sir on auscultation. Sir,
So
we
you
would
want to
find.
examine the respiratory system first.
Yes, sir. We'll examine the whole
And the
respiratory
respiratory
system.
system, what you will look for? Remember that you are sitting in OPD.
Yes, sir.
क्या देखोगे?
Yes, sir.
Where would like to concentrate on the respiratory system examination?
Sir, on auscultation.
You are like to concentrate on auscultation.
Yes, sir.
And what you are expecting in auscultation?
Sir, fine and inspiratory creps.
Fine and inspiratory cracks. Okay.
Yes, sir.
Okay. So you wanted to see the breath sound and you wanted to see the accompaniments. And in
Yes,
accompaniments,
sir.
so while you examine, there was bilateral inspiratory creps, right?
Yes, sir.
And no other finding was there. What you suspect with this history and with the and any others? So that was a respiratory system examination. Now, of course, you have to examine the other relevant system. So,
Sir,
would you like to examine any other relevant system here in this
yes, sir.
case?
Sir, to begin with, sir, we would go with the cardiovascular system. So to rule
Uh,
out any signs of pulmonary arterial hypertension. So
okay,
following which we'll examine the skin to
the
see for
skin.
sir any skin lesions,
Yes.
and then we would further go with the
What would like
GI
to
tract.
what would like to see in GI tract?
So tender hepatomegaly,
Yes.
and so we would also examine the musculoskeletal system to rule out joint pain
Okay.
and muscle weakness.
So you when you examine all these other system, there was nothing positive. So only finding in systemic examination of there was a bilateral inspiratory cleft in both infrascapular areas. Now what is your impression? What are the differential diagnoses you are likely to
Uh,
face?
so to begin with, this is it appears to be a restrictive lung disease.
Okay,
Sir, specifically, sir, it could be ILD, interstitial lung disease,
okay.
like sir IPF.
What prompted you to think that this is a restrictive lung disease? ऐसा तो हमने
Due to
डायग्नोसिस में हमने नहीं सुना अभी तक.
जी सर.
अब जब आप हिस्ट्री लेते हो तो ये थोड़ा डायग्नोज करते हो कि ऑब्स्ट्रक्टिव लंग डिजीज है रिस्ट्रिक्टिव. Probably that is very well. Sometimes you may find ऐसा तो नहीं बात करते ना, बात तो करते हैं कोई in terms of diagnosis.
Diagnosis, sir, ILD.
So you are suspecting ILD. Any other suspicion? You said hilum is also prominent. You said there is a volume loss on the left side. These two findings also you have observed while you are reading the chest X-ray. So does it have? My
Yes,
arrow is visible.
yes, sir, yes, sir,
So do you see this area?
yes, sir.
What is your comment?
Sir, it is an opaque shadow.
Okay,
It could be lymphadenopathy.
could be lymphadenopathy. Okay,
Yes, sir. So
and this
since
even there's a hilum is enlarged, so it could also be lymph node.
yes, sir.
You said the
And
right
so
hilum is prominent.
yes, sir.
So there could be. So you have examined the lymph node in the physical examination to be very precise in general examination, but there was no lymph node.
No, no.
Okay.
Since she is 55 years old, so there could be a possibility of any lung malignancy that we can rule out.
So how you proceed now with all these things in the mind? How will you proceed this case?
Sir, going forward, so we would, get her spirometry done, sir. 6-minute walk
So
test.
first you will do spirometry or first you will do any other investigation?
Sir, HRCT.
HRCT. You can do HRCT if it is available. Would
Yes, sir.
like to do? Huh?
Yes, sir. Yes, sir.
You are
Definitely.
suspecting ILD. In ILD, probably the HRCT is one of the very important investigation.
Yes, sir.
right? So I see that if you have HRCT, so yes, before HRCT, yes, now you have got HRCT. This was the HRCT in 2001 when he has received 3-4 months of ATT and 2-3 months of inhaled medication. So what do you find in HRCT?
Sir, there is, sir, septal thickening.
Septal thickening.
Septal thickening, sir, subpleural honeycombing.
There is subpleural honeycombing.
Sir, and evidence of fibrosis.
What is the evidence of fibrosis?
So there's volume loss.
Volume loss. How you can find out volume
And sir,
loss?
no,
नहीं,
sir,
volume loss CT में कैसे
honeycombing.
पता लग गया? How you find out volume loss in CT scan?
So वो गलती से बोल दिया.
भाई एक्सरे में तो समझ में आ सकता है. So you find that there is a typical that her lesions are, what is the, when you read CT, especially in ILD, how you read? Your first thing is what is the distribution of the shadow?
Yes, sir.
So what is the distribution of the shadow?
Sir, predominantly subpleural.
No,
lower lobe, sir, lower lobe.
No, even in middle lobe, this is the first
sir,
cut is at the level of
middle lobe.
Middle lobe,
Yes, sir.
mid zone. So there is mid zone, but predominantly in lower zones.
Lower. Yes, sir.
And it is subpleural in location. Mainly subpleural in location.
Subpleural in location.
So these two things are there. So and even some, what you see here, what is this? What are these? Some
cysts.
Some
and
cysts.
cysts, sir.
Some cyst is also visible. So now after that you ask that after the CT scan, so what CT is suggesting? What type of ILD?
Sir, IPF, sir, idiopathic pulmonary fibrosis.
Maybe because of the distribution, because of the type of shadows, it may be case of IPF. So what is the next investigation?
Sir, pulmonary function test will proceed with spirometry to see, sir, FVC values.
So this was the pulmonary function test of this lady in 2001.
Yes, sir. Sir, FVC is decreased.
What it suggests? अरे सामने क्या suggest कर रहा है ये?
Sir, restrictive pattern.
This is restrictive lung disease.
Yes, sir.
Why you say this is restrictive lung disease?
Sir, FVC is reduced.
So only by if FVC is reduced, you will say restrictive lung disease.
No, sir.
But what should be the first thing to say that there is a
given by FVC.
FV upon FVC.
Given by FVC.
So do you have this here? No.
No, sir.
No, sir.
Sir, नहीं sir है.
What do you want for FEV1? For FEV1, these are the spirometry. What we say, these are two primary values.
Yes, sir.
What is essentially required to interpret spirometry. And in that interpretation, what you find that ratio is maintained. It is not less than 0.7. So straightforward, you can say if ratio is maintained, and then next thing you see about the FVC. And FVC definitely for that particular lady, this is much less. 0.68 is very low figure. So you can very clearly say with confidence that this spirometry had restrictive type of a lung disease.
Yes. Yes.
No obstruction. So why he was prescribed inhalers? She was prescribed?
So that was due to wrong judgment she was prescribed, sir, inhalers.
Maybe because of the wrong diagnosis. Why she has received ATT?
Sir, again because of the wrong diagnosis.
Now you can pretty say, well, there might be some associated tuberculosis also. There might be some associated bronchospasm. For that, some doctor might have advised a combination of steroids and LABA. But by whatever history you get, but when she has no response, and now spirometry is clearly telling you there is no evidence of obstructive airway disease, so it means possibly those prescriptions were because of the misdiagnosis, which was very common in the 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 case I when in 2000. 2000, what was the awareness of ILD in 2000?
Sir, very
You know
less.
the first guideline of ILD came in
2008 or 11?
2002. You must
2002.
go through and read
Yes,
that.
sir.
That is very elaborate guideline. How to diagnose, how to treat, how to assess the prognosis, how to follow up these cases. I think that was one of the very vivid, clear cut guidelines. First time came in 2002. So it means awareness around 2000 of these diseases are very low. That was the reason why she was prescribed anti-TB drugs and about the bronchodilators and inhaled steroids. So that was very common at that time. Now what you say after you have seen the CT symptom X-ray, now you are confident that what is the diagnosis?
Sir, it is IPF.
IPF. Any other PFT would like to do while you're
So,
talking into 2021?
DLCO.
DLCO. Very good. So DLCO diffusion must have been done. Why it was not done at that time, 2000?
Sir, due to unavailability or sir,
Because diffusion machines were not very
inavailability.
common in 2000. Hmm?
So
So
it's not available then.
only possible investigation was spirometry. And okay. So if it is IPF, and you know that how you are going to treat this patient, how it was treated in 2000, first you let me know. What was the
Sir,
guideline in 2000?
as a
I
thyroid.
said in 2002 the guideline came. So what was the treatment in that period?
Sir, to begin with, sir, steroids and
Yeah.
sir, later on there were trials, sir, which used as a thioprine plus steroids. So that came
Yes.
on later. So that and sir, there was also a study using N-acetylcysteine, which now shows no role in IPF.
Okay. So
And sir,
so initially the treatment of practically all sort of ILDs were a combination of steroids, other immunomodulators like azathioprine. Some people used to use
cyclophosphamide.
cyclophosphamide, and then combination also combining with N-acetylcysteine.
Yes, sir.
So this was a very common treatment prescribed in those days. So she was also prescribed same treatment. Naturally, whatever treatment was available.
Yes, sir.
When the pirfenidone, when these anti-fibrotic drugs were came in the treatment practice.
Sir, 2011.
Hmm.
Sir,
So
with
now, okay, now we have two main anti-fibrotics. Which are those? What is difference between these two drugs?
sir, nintedanib, sir, acts on VGEF, TGF beta, and sir, thus reducing fibrosis. And so, pirfenidone
What is the difference in doses of these two drugs?
Sir, doses, sir, for perfenidone, sir, we begin with a low dose, and sir, weekly, sir, we increase the dose to up to 2,400. And for sir, nintedanib, it is 150 milligram BD.
Okay, straight you go 150, or you initially initiate with
Sir,
less doses?
initially we start with 100 milligram and see whether the patient is able to tolerate, and then
Yes.
sir, further we increase it to 150 milligram BD.
Okay. And what are the differences in their adverse drug reactions about these two antifibrotics?
Sir, gastric intolerability. Sir, with perfenidone it is more, and nintedanib it is less. And sir, nintedanib causes constipation, whereas perfenidone causes sir more of diarrhea.
Okay. No diarrhea with nintedanib?
Sir, sir, mostly it causes constipation and less of diarrhea. Sir, or I'm confused probably.
What
Sir,
is the
dono
effect on liver function of both the drugs?
uh, it does elevate, sir, the transaminase. Perfenidone.
Okay. And what is the duration of treatment? Suppose this is IPF. What is the duration of treatment?
Sir, lifelong.
Lifelong, till person is alive.
Yes, sir.
And can you tell me that when this which trial actually, this is that's such a landmark trial which said that steroid is not useful in the management of IPF. What was that landmark trial?
Impulses.
Impulses तो बाद की ट्रायल है भाई. वो ट्रायल क्या थी जिसने बताया कि I said initial treatment was combination of the very popular. Even this lady received a combination of steroids.
Sir, inbuilt trial.
As inbuilt. Oh, bilkul. Huda, you are somewhere lost. If you answer like this, inbuilt trial. Can you tell me what are the trials which brought perfenidone? Perfenidone किस trials के बाद आए?
Perfenidone से किस
nintedanib किन trials के बाद आया?
सर nintedanib तो impulses trial के बाद आए.
तो impulses trial की बात क्यों कर रही हो तुम? हैं? Why you are talking in? My question was, which was it was very famous trial, which is negated the role of steroids in IPF. Then people started searching all these anti-fibrotics drugs. Which trial talks about the perfenidone?
Panther, या सर सारे ट्रायल्स.
सारे ट्रायल्स, यही तो कहता हूँ ना कि सारी ट्रायल्स को प्रेजेंट करो सेमिनार में, सारे ट्रायल्स को पढ़ो.
सर पढ़ा था पर अभी सारा कंफ्यूज हो गया है.
कैपेसिटी 1, कैपेसिटी 2, कैपेसिटी 3. You have to be knowledgeable. You have to be run with this. You have to go with the science available. And that was the Panther trial, which negated that steroids are rather harmful.
Yes, sir.
Can you answer my one question? Now, we said that in IPF, the steroids are not prescribed. It's rather they say it may cause harm. Right? Actually, if I may tell you the history of treatment of IPF, initially it was high dose of steroids. Then the concept came that low dose steroids with combining with azathioprine and combining with estyle. That was very popular treatment that remained for about 7-8 years. Then the capacity trial has started perfenidone, and all the capacity 1, 2, 3 has proven this. Yes, this is an effective drug. So what I'm trying to say, you have to be well conversant with these trials.
Yes, sir.
Can you tell me my question to you is, In IPF, which is the condition where steroid is still used?
Sir, exacerbation of IPF.
Very good. So it's meant some, you know that in IPF there is known as exacerbation, acute IPF, and
Yes, sir.
in between patient may go, and that is the place where steroids, rather high dose of steroids are required.
Yes, sir.
Hmm?
Yes, sir.
What do you think is prognosis? Know I treated this lady, Huda,
Yes, sir.
and you have seen that I started in year 2000.
Yes, sir.
What do you think? What should we suppose patient ask you? You have seen X-ray, you have seen CT, you have seen CT and PFTs. How you like to answer the family members? What
Sir,
is the prognosis of my? What will be the prognosis of my patient?
so poor prognosis.
What do you mean by poor prognosis?
Sir, the
Tomorrow,
survival.
tomorrow, tomorrow she'll die.
No, sir.
Then
Sir, from the time of diagnosis, sir, 1 to 2 years.
1 to 2 years.
Yes, sir.
No. Usual from diagnosis, if you treat the patient, usual time is average. Mean time is about 3 to 4 years.
Okay,
And
sir.
what is the mean time for lung cancer also? Right? That is why people say that IPF is as prognostically, the IPF is as bad as lung cancer,
Lung cancer.
except small cell lung cancer. Small lung cancer has a very poor prognosis if you don't treat. Can you tell me, Huda, what is the prognosis of small cell lung cancer? If you treat and if you don't treat.
Sir, if we don't treat, few months. Sir, 3 to 4 weeks for limited, sir, 3 to 4 weeks, sir, for small cell cancer.
And
Uh,
what about that? So, and small cell lung cancer is divided into,
sir, to limited stage and sir, extensive stage.
this is true for both disease,
Sir,
limited
this
and
is for the
extensive.
this is for the extensive stage.
This is for extensive disease, okay?
Yes, sir.
What
And
is
for
for
limited,
limited?
sir, it is 3 to 5 months if the patient is not treated.
Not treated, yes. So that is why this is the small cell lung cancer. Usually in cancer, or so in lung cancer also, we talk about 5 year survival. But it was the small cell lung cancer when people started talking 2 year survival. So maximum survival may be 2 year for small cell lung cancer with the best treatment,
Best
right?
treatment. Yes, sir.
But if we don't treat, you said very rightly that if the disease is extensive at the time of diagnosis, which is usually there, because the small cell carcinoma is very rapidly
Aggressive.
multiplying, very aggressive tumor. Usually at the time of diagnosis, usually it presents in an extensive stage. So there, if you don't treat, life may be 2 to 3 months. If you treat, yes, you may prolong about, you may give life up to 3 to 6 to 9 months. In a disease is extensive. But if you overall prognosis of 2 year survival for small cell lung cancer, how it is talked? 2 year survival is not for 5 to 10%, not more than this. So it's a very aggressive and very poor prognostic lung cancer, small cell. Otherwise, non-small cell lung cancer they behave usually with like any other cancer. So anyhow, that's why the people talk in IPF that it is as bad as lung cancer. Can I tell you how she lived? I know that since I have followed this patient at this moment I don't have, but in my other presentation I have full follow up of this patient. For your information, this patient died in somewhere near 2007, I believe, if I remember correctly, 2007. So what I'm trying to say to you, and there was no anti-fibrotics at that time. She was treated with the help of all those drugs like low dose steroids with the azathioprine and with
Cyclophosphamide.
with
Like 16.
with the style system. So what I'm trying to say, every individual differs. What we talk is the mean. Mean means, suppose mean duration, mean lifespan is say about 3 to 4 years. So it may be 2 years for a patient, and it may be 6 7 years for another patient. But if you combine all the patients, so what we talk is not every patient will die in 3 to 4 years. So some
Yes,
of them will die or may die early. Some of them may die depending upon what is the scenario, what are the comorbidities, what stage he or she was detected, everything. But this lady, I know that she came to me in 2000 and she was alive till 2007, if I remember correctly. And at the 2007, actually, she had an acute exacerbation of IPF. Again, at that time, acute exacerbation was not very well known, but anyhow, but we have diagnosed. She became very sick. Shadows increased all of a sudden, and ultimately, in that we could not save her, and so lived for about 7.5 years, I believe. So what I'm trying to say, when we talk of mean survival, it's a mean survival. Some range may be too much. So this patient, I still remember. If I have been careful, have you there when we did national CME and ILD?
no, sir.
तो अब तुम्हारे बैच का कोई नहीं रहा होगा, कोई रहा होगा? अच्छा,
नहीं
JR3
सर,
लोग नहीं रहे होंगे। क्यों, तुम
नहीं सर,
लोग किस
हमारे
ईयर में?
सर हम 2018 में आए सर, हमारे सीनियर्स का शायद था।
18 में तो हुआ था वो, आई बिलीव, इफ आई रिमेम्बर
हम लोग थे सर।
हम
लोग थे सर, मैं था सर।
अच्छा, आप थे। I have shown this case and I said that this variation is there. She lived with old conventional treatment for about 7.5 years, 8 years. I don't remember exactly.
Sir, 6 monthly, sir, PFT and DLCO follow up with PFT and DLCO, sir.
Okay. Not about HRCT, thorax?
Sir, yes.
You have to follow up. If I would have been your place, you have to follow up with these patients very regularly with their clinical symptoms, with adverse drug reactions, and then most of the guidelines says that you can do with spirometry and diffusion every maybe 3 to 6 months, and then CT scan maybe 6 months to 1 year time. That is how the follow-up is being done. And how you will say that patient is responding, not responding, what is the criteria to tell?
Sir, a decline in, sir, of FPC by 10% and 15% of DLCO. Sir, हम बोलेंगे कि sir patient respond नहीं कर रहा है.
Okay.
Sir, अगर values sir FPC और DLCO के sir same है when compared, तो sir disease sir progress नहीं करी है.
Okay. So and can you tell me what is the advantage of using anti-fibrotics in these patients, IPF?
Sir, it halts. Sir, it slows the progression of fibrosis.
Okay. What effect is there on the mortality?
Mortality, sir. It reduces mortality, sir.
Are you sure it reduces mortality?
No, sir. Sir, mortality पे sir इतना उसका कोई effect नहीं है. Quality, it improves the quality of life.
Quality of life.
Yes, sir.
So your preparation is not good, Huda. I must say one thing. So so you should know all these. कि भाई क्या है इसका, how it is followed up, how you decide. Now there are vivid guidelines, and these are the questions which will be bombarded to you.